I used to get major suicidal thoughts. I just thought life was not worth living. I thought that I was a waste, and I did contemplate killing myself on multiple occasions.
The only thing you can tell your child is that you mean the world to us. What am I without you then? And of course, pray.
People with bipolar have 20 times the higher risk of suicide than others. So it's really something that, again, you want to prevent.
This is Zen-Brain, a platform where we discuss stuff that you otherwise don't, especially the intricate connection between our emotional, mental, and physical health. One of the topics that we've had a lot of inquiries about since the very, very beginning is surprisingly the much misunderstood and unfortunately stigmatized bipolar disorder. So if you Google bipolar disorder, this is what you'll find. You'll find that it's a serious mental health condition where a person experiences extreme moods, phases of depression, and massive highs. Now, first of all, researchers do believe that most youngsters, especially during puberty, between the age group of, say, 16 to 25, will go through phases of lows and highs, which is to do with hormonal changes. So how can you really tell whether it is something more serious like clinical depression or a serious mental health condition like bipolar disorder? Today, we will hear from 25-year-old Mriganko Banerjee, who lives with bipolar disorder. With him is his mother, Mitali Banerjee, who has been instrumental in her son leading a pretty close to what one would call a normal life. They are joining in from Mumbai. So thank you for joining us and welcome.
Thank you so much for having us here.
And also joining us all the way from the University of Massachusetts Medical School in the US is Dr. Sonal Singh. He's an associate professor and a practicing general internist. Dr. Singh was previously with the Johns Hopkins University as a scholar and clinical researcher. He has received several awards and has published more than 150 academic manuscripts. And dare I say, he is passionate about medicines related to mental health. He also is intimately familiar with bipolar disorder and has helped many, many patients over the past few years. So why are we having this discussion? This is really to understand what bipolar disorder really is and to remove stigma in our heads about this condition. And I hope one of the key takeaways is to treat people with mental health issues like bipolar disorder, just like you would treat someone with a heart condition or diabetes or hypertension. So let me start with you, Mriganko. What, according to you, is bipolar disorder?
So I look at bipolar disorder as if it was a graph. So if you took time on the x-axis and mood on the y-axis, it's a series of ups and downs in how your mood fluctuates from time to time. And the ultimate goal is to be at a stabilized mood all the time.
Mriganko, when was the first time you felt something was not quite right?
So the first time I felt this way was when I was 16. I had just completed my class 10 exams, and there was a lot of confusion, and it was just a very difficult period of time for me because I was continuously talking and I was all the time exhausted, but I couldn't sleep. So that was, I think, when I realized that something was going wrong.
Mrs. Banerjee, what prompted you to take him to the hospital and have him admitted for the first time? I didn't even have any idea about what this was, what bipolar disorder was. And I didn't even pay attention. I was just thinking that it's a passing phase and he's just been through this examination and he probably has taken on too much of pressure. And he's basically always been a very good student and he's always taken on a lot of performance, stress. So I thought that maybe, it is that. And after the exams are over, he's going to be okay. And honestly, we did not notice too many changes. Like that, he was exhausted and all of that. We attributed all of this to his exam stress. Then suddenly there was a time when he started talking too much
and he would skip from one topic to another, and there was no connection between the two topics. And slowly it's kept increasing, and sometimes he would talk about things that we had never thought about, and he would get into arguments and all of that. Then there was one day, that's 30th of April precisely, of the year 2013, when I came back from office, and basically all day my daughter was with him, and she before leaving for college, she told me that you must see something is wrong with him, and when you come home, just talk to him. So when I came back from office, I saw that he was pacing the house, and he was continuously talking, and he wasn't eating. He wasn't even aware of the food that was lying about. Now, he was not aware of what was all around him. So somehow I fed him, and then I tried to calm him down, but I saw nothing was working. So I only thought that I'll take him to the counselor the next morning. And then I asked him to come and sleep in my room. Now, what happened was that suddenly he started talking about a TV in the room, and we did not have a TV in the bedroom. He said, "Look, there's an interview going on with Barack Obama. I'm interviewing him." So I said, "Where?" He said, "It's on the TV." "Where's the TV?" "See, it's on the wall. See the TV." And very casually. So I understood that there is something majorly wrong, which is something I can't understand, and this needs to be addressed. So I thought that I'll take him to the counselor. Next morning, I took an appointment, an urgent one, and I took him, and he walked with me. And just to check if everything was okay in his mind, I asked him to withdraw some money from my ATM just to check if he remembered the PIN. And he did. He withdrew the money, gave it to me, and I was still confused to know what is happening. So now here the counselor told me, she spoke to him for 2 minutes, and she said, she took me aside and she said, "Ma'am, this is not it's not, I can't do anything about it. You must take him to a doctor. I think he needs hospitalization." And it was like, the world had collapsed. She said, "He's got a mental illness and you have to take him." And I thought, my God, now what? So then I did contact, she said, I'll help you. I'll talk to my boss, the doctor I work with, and you can take him there. So we took him there. And it was 1st of May, the day we were doing this. And knowing we were in Kolkata then, and Kolkata, everything is shut that day. It's May Day, so everything was shut, and the doctor also was not available. So then we took him to another hospital where I knew I had connections. Took him there, went to the emergency, and the first thing they said was that, "Is he on drugs?" I said, "Not that I know of." Said, "We'll have to run some tests because I think he's hallucinating, and which is because of drugs." So I said, "Okay, please go ahead because I am not aware. Maybe he is." So then they took the tests and all that, and he was clean. So then they sedated him, and they called their visiting psychiatrist to come and visit him, to see him. And then he said that, yes, it is a mental illness. It's, I think, psychosis. But right now he's not in a position to, tell me anything, or I will not be able to diagnose right now. Let me start him on the basic medicines. Let him calm down and come out of this, and then we will start the treatment. So that's how it was.
So they suspected that it could be psychosis. Dr. Singh, let me bring you in here. What could the symptoms of bipolar disorder be, really? And I want you to take us through clinical and otherwise as well.
I won't be able to dispense medical advice. I'm just going to interpret what you've been saying and what is characteristic. So a lot of the symptoms, sleep disturbances, pacing, excessive flight of thoughts, and others that are more characteristic are excessive spending, excessive sexual activity, yes, use of drugs, alcohol. All these coincide with symptoms of mania. And as Shruti mentioned earlier, I mean, some high moods are normal. I mean, we all go through those phases. What distinguishes it from being classified as bipolar is the fact that they affect our function, interaction, day-to-day interaction with people. So you could have high mood or low mood, but if you have, cycling between high mood and low mood, that's when you have bipolar, particularly if it's affecting your performance in school or performance at work. In this case, what you've described is a little, it's not uncommon, but presenting with psychosis is a sort of break from reality when we start seeing things or imagining ourselves as things, which was quite severe and required hospitalization. It is not uncommon in bipolar disorder, but it's much more common in the psychotic disorders that have, but it's people with severe bipolar at initial presentation can present with these breaks from reality where they start seeing things and imagining things that requires more aggressive treatment, hospitalization, as in the case we are discussing.
Yeah, this is an important point. So I think perhaps loved ones who are faced with this situation are aware that it is more serious than they think it is. So let's move on to these extreme highs and lows that we talk about, which really is what bipolar disorder is all about. Mriganko, talk about what it feels like when you are extremely low, and how do you really differentiate between feeling low and depression? And of course, also the extreme high state.
Okay, so I'll start with the low. There is a stark difference between being sad and being depressed, at least as far as I go. So when I'm sad, there is a reason for that sadness. That reason for that sadness is very different from the trigger of a depression. It's a solid reason. There's a reason I'm sad, and I can tell that I'm feeling sad. I feel upset, and when I'm depressed, there is this very hollow feeling somewhere within. There, I feel a very heavy sensation on my chest. I feel like crying all the time, and I give myself that liberty to cry, uh, because to me it provides me with a lot of relief. And if I have to stay in bed, I stay in bed. But the thing about depression, or for that matter mania, is that there is a time period where you are your reasonable self, where you are slightly lucid, and that is the time when you need to make up your mind to reach out and seek help.
There is a period where you are aware of the fact that you're slipping into depression,
Yes.
or you are in that state, and it's important for you to tell somebody about it, right?
Yes.
Carry on.
So when mania first begins, it is extremely enjoyable, because you give yourself the liberty to say the things that you usually wouldn't say, do the things that you usually wouldn't do. You don't have any inhibitions. You can go up and speak to anyone. You can hit on them uh, without any fright. So it's very enjoyable, but the problem with it is that it goes downhill very fast. There has to be some sort of understanding of yourself that this is not my regular self, and it is very important to seek help again.
Mrs. Banerjee, let me come to you. Mriganko spoke about what he feels like and these extreme highs, which are very enjoyable to him. How do they appear to you as somebody watching him? And how do you handle it?
It starts with a sadness. He wakes up feeling very sad and grumpy, and if he's crying, and there is no reason. Of course, there he must be going through something. But the first feeling that happens is that my child is hurting inside, and I can't see, because if it is a wound or an ailment which it's in the tummy or it's in the heart or somewhere, then you know what to address and how to address it. But this is something, every time he is depressed, it is a different kind of a feeling. And it is really, first thing is that it's very sad. Even for me, it is very sad to see him hurting that way. Then you have to take charge of the situation, because he's not in a position to do anything, so you have to help him. So either he's sad when he's depressed, or he's too fidgety when he's feeling a little high. So that is a little easier for me to handle at this stage, because you can tell him that you're fidgeting too much, is something bothering you, and then you can, go for medication or counseling or whatever. You can reach out to the doctor. And both feelings, he may say that they're nice or whatever, but they're not good at all. It's very tough to watch him go through all this. So and I don't wait for too long. 2-3 days is enough for me, and then I do contact the doctor or the therapist. And the therapist also knows the threshold. She tells us that no, now this you have to talk to the doctor, and probably he needs a little medication now. So the moment the medication is given to him, it takes a few days, say another 2-3 days, and then he stabilizes. And once he starts taking the medication, then I think slowly this feeling of wellness comes in. And then he slowly takes charge of it. And he himself comes and says, Mama, I'm today feeling better. This medicine is working. And then we are in regular touch with the doctor. And we have been able to handle it.
It's an important lesson to take away from you, Mrs. Banerjee, because as a mother and as a caregiver, it is very important for you also to be extremely vigilant. Dr. Singh, what can someone going through any of these extreme moods do to get help? And what can caregivers and loved ones do during these extreme states? We've heard from Mrs. Banerjee, but what, according to you, would be some of the things that they can do?
I'm glad that things are okay here, but I think it's very hard to manage somebody with excessive mania, or for that matter, depression. So the earlier we recognize these states, the symptoms that you described, as well as excessive spending, in some cases sexual activity, use of pornography, use of drugs, all of these are pleasurable activities, and the consequences are bad. It's the pleasure is there. The brain, enjoys these because our judgment part of the brain, the front part of the brain, which, does not worry about consequences. It's the basal ganglia, which feeds on dopamine, just enjoys these activities. And the other part to recognize is the more you have these episodes, the more hardened it is, and the harder it is to treat the next episode. So we have to treat the first episode very, very aggressively. And we have to recognize that friends, family, and try to get them aggressive help, psychotherapy, as well as medication therapy, and in some cases hospitalization very early. So early treatment, early diagnosis, and recognition. And again, things like sleep. Sleep is both alteration is a symptom of bipolar as well as a trigger. Sleep deprived, you're going to trigger bipolar, and the first recognition in the family if there's a sleep alteration, and or alteration in family, pattern recognition. So everybody should recognize their patterns when they wake up, when they do activities, and if there are changes in patterns, then you know that something is about to change.
It's very interesting, Doc, that you brought in the activation of the pleasure pathways and excessive dopamine that is released into the brain, right? Can you just explain to us a little bit about the connection that it has with addiction as well, and therefore it needs to be managed even more?
So yeah, addiction pathways, and I mean, all of these are related to, in crude terms, control from our frontal, brain, which controls sort of our basal brain, which is linked to emotion and pleasure. I see a beautiful girl walking outside my window. I want to go and say hello, but my frontal brain prevents me that this is, from a professional perspective as a doctor, I won't do that. If I have bipolar, I don't have that inhibition. I can go out and do that. And the same thing with use of heroin. Your inhibition is gone. It stimulates that, and once you're addicted, this is a self-fulfilling loop. It just keeps going on. So, and not to classify someone as a drug user, but the chemical pathways in the brain for addiction and some of these pleasure pathways are not dissimilar in those with bipolar and or other illness than, say, heroin abuse. So we're activating the same pleasure pathways. in both cases.
Very, very insightful information, as we do know that too much of dopamine causes a chemical imbalance in the brain and body, and therefore leads to very serious consequences. We talk about different levels of bipolar disorder. Very quickly explain to us, what are these various levels?
You have bipolar 1, which is the most aggressive form, where you have real high episodes of mania alternating with depression. Then it's bipolar 2, where it's hypomania. So some of those manic episodes are not as the impairment. There's still impairment, because you need to have impairment to classify it, but it's not as bad. You can still go about doing activities. People think, oh, you're this happy-go-lucky guy. You speak to everybody. So there's still some impairment, not as bad. And then there is this cyclothymia, which we describe as alternating, very rapid cycling between high mood, low mood, high mood, low mood at around a baseline, again with impairment. So I think these are the three types. Bipolar 1 is the most common, and probably the most damaging in terms of consequence, because and the most damaging consequences from bipolar disorder arise in mania, including suicidality, including impairment of function. So, bipolar disorder is the leading cause of disability in the world, one of the leading causes of, and it's also one of the leading causes of suicidality in the world, in terms of risk.
So moving on to diagnosis, let me ask Mrs. Banerjee here. So when you admitted your son to the hospital for the first time, you mentioned that the doctors at that time thought it could be psychosis. So how long was it before his condition was actually diagnosed as bipolar disorder?
There was, for the next 5 years, it was just very short episodes of highs and ups and downs. And there was a lot of trial with the medicines. And the moment there was a depression, and they treated him for that, then he would go into a high. Then again, that had to be controlled. So then that caused depression. So it was like a loop. It kept going up and down. 2017, there was another major episode of high. Now, before that, he was a little depressed and a little grumpy. So I thought I'll take him to the doctor. But his doctor, the regular doctor that we were going to, was not in town. He was, in fact, not even in the country, so I couldn't contact him. So I took him to another doctor who prescribed some other medication. And before I could get home, I could see that this was going to be bad. I mean, but I hadn't seen this high before. And then when we got home, the next some hours, it was like hell. Hell just broke loose in the house. And he's a large 6 foot plus young man. And for me to control him was like next to impossible. So I just locked the collapsible gate and I kept the keys with me. And I thought, whatever happens, I'm not going to allow him to go out of the house. And then he damaged stuff in the house. He broke things. He was trying to, there was so much of physical energy. I had to call up the hospital and ask them to come and pick him up. There was one particular medicine which could calm him down. So I just gave it to him and he calmed down for a little while. Actually, he fell off to, I think it's a sedative, so he fell off to sleep. And then we did take him to the hospital again, and he was there for more than 10 days, 15, I think 2 weeks he was again in the hospital. Then after that, when he came back, then he was stable for some time. He completed his college and then he came here and started working. 5 years of trial and ups and downs.
Okay, we are going to get into medication. That's very important. But before that, Dr. Singh, there seems to be a very thin line between conditions like psychosis, paranoia, even early symptoms of schizophrenia, clinical depression, and of course, as we are talking about, bipolar disorder. So how do you reach a diagnosis?
Let's talk about just bipolar. What happens in bipolar, we're talking about both mania and depression. And as in his case, he had some psychotic symptoms as well. It takes a while to make the diagnosis because people are not familiar. They just label it as, well, altered mood, or you're depressed. And the challenge with depression is sometimes use of antidepressant medications can precipitate mania. So it is very important to make an accurate diagnosis of bipolar and treat with mood stabilizers. Otherwise, blanket use of an SSRI or, serotonin inhibitor in patient with a bipolar, thinking that they have depression, can actually precipitate mania. And it is quite common. And that's when the diagnosis occurs, use the wrong medication. And so I think important to make the test. The other disorders, such as the psychotic ones, it's really a break with reality. Delusions of grandeur, you feel like you are, Modi, hallucinations, auditory hallucinations, hearing things, saying things. And they can coexist with bipolar. Some people have both, rarely. Some people have a combination, what we call as a schizoaffective. So it's a mood plus psychosis. And sometimes some of these psychotic symptoms, as in this case, occur as a part. So you can have both. You can have a combination condition, and you can have symptoms of psychosis as a part of bipolar. So we need to make an accurate diagnosis, because psychosis is more about thoughts, abnormal thoughts, emotions, behaviors. Person's behaviors change. They start saying things that don't make sense. It's hard to relate to them. So that's requires a separate, much higher level of support, different antipsychotic treatment. So these are conditions that can coexist, but are different as well.
A very important point that you brought up, Dr. Singh, is that certain medications can actually precipitate the condition. So one has to be very watchful of that. Now, medication for, as you mentioned, for any mental health condition requires a level of trial and error, and doctors have to experiment with them. So therefore, it is important for caregivers to monitor the patient's behavior very closely. Mrs. Banerjee, in Mriganko's case, how long did it take you, to actually come to a combination that was right, that was working for him?
This was in 2019. Finally, when early 19.
So which means that it was 5 years into the diagnosis.
6+ years, almost 7 years.
6 years after his hospitalization. I'm just specifying.
Yes, after the first episode. After the first episode, it took about 6 years to then the doctor started him on lithium, and ever since he has been stable.
Dr. Singh, do you want to add to that? You've done extensive research on medication, keeping in mind that all patients are unique. Is the overall medication combination the same in patients suffering from bipolar disorder, or barring some medication that is common, are the combinations different for different people?
Yeah, it's a very different, combination for different people. But, lithium, again, we have a lot more options now. And lithium was the first medication, and has really good effects, particularly against prevention of suicidality. We really don't know exactly how it works. We think that it affects sodium channels, was discovered in Australia. But it's a very effective medication and works for suicidality, and for whom it works, it's a good medication. The only thing is, again, like any medication, requires monitoring. His kidney function, thyroid, those things. Some people need to drink a lot of water and pee a lot of water. Lithium is a great medication for bipolar disorder, works well for him. But now we have mood stabilizers, and mood stabilizers like, they're known as carbamazepine, they're valproate, and then a whole host of antipsychotics. So these are newer medications, work for other people, combination medications. They have a little less chance for side effects. So for some people, there'll be a trial and error. It'll take a period of time before we find the right. The other point I would like to make is that you don't have to wait for episodes of bipolar to treat. We want to prevent these occurrences. So, you need to be on a regular mood stabilizer on a daily basis. And unfortunately, for most people, That means a lifelong mood stabilizer therapy. So we're not talking about, well, we are going to wait till you have depression or wait till you have mania and treat it. It's harder at that time. You have to be on a steady level for long periods of time.
Any changes in medication should be discussed with your doctor rather than self-medication. Another point that I want to just mention here is the danger of patients stopping their medications is rather high in both extreme conditions. When they are low, they just don't feel like it. And when they are in the hypomania state, they feel they don't need it and tend to skip their medication. And hence, there is always a danger for them to slip.
Yeah. I think that, you forget about your medications. And the other part is mania is so pleasurable, you don't want it to stop. So people who are in stages of mania is one of the most pleasurable things. And so people in mania don't want a medication that will bring them down to earth. So why would you want to take a medication that takes away all this pleasure you're having in spending, addiction, sex, pornography? So I think that's why prevention is better than treatment of mania.
Medication also brings us to a very important aspect of bipolar disorder that you've mentioned, Dr. Singh, which are suicidal thoughts. So let me start with Mriganko here. Have you ever had suicidal thoughts?
Yes. So this started when I was 19, I think. I think it was half a year before my my second hospitalization. I used to get major suicidal thoughts. I just thought life was not worth living. I thought that I was a waste. I wanted to disappear. I wanted to go away somewhere. And I did contemplate killing myself on multiple occasions.
Mrs. Banerjee, as a mother, I'm sure it was terrible knowing that your child was having such thoughts. How did you handle it?
The first devastating. It is just devastating to hear from your child, I'm worth nothing, and why do I need to live, and what difference am I making to this world, and all of that. So the only thing you can tell your child is that you mean the world to us. What am I without you then? If you think you're not worth it, then even I'm not worth. What am I? I mean, I don't have anything else. You're all I have, you and your sister. So I and of course pray. That's it. I could only pray that he is protected and he's safe.
Dr. Singh, there is, of course, the emotional aspect that we've just heard. But would you say that there is a hormonal or neurotransmitter imbalance, very much part of most serious mental health issues? And that's why the stress on medication to bring back a level of chemical balance. So how much is suicide visualization or having suicidal thoughts part of this chemical imbalance?
For this sort of discussion, I actually went back and looked, and obviously there is chemical imbalances in mental disorder, but very, very specific to suicidality. There are characteristic, what we know are characteristic alterations in three hormones: serotonin, noradrenaline, and dopamine. And this is linked to suicidality. We know that the serotonin metabolites in the brain are lowered in people who are suicidal. We know that noradrenaline metabolites are lowered in people who are suicidal, and dopamine linked to aggression. So these three, noradrenaline, serotonin, and dopamine in particular instances together interact. And we know people with bipolar have 20 times the higher risk of suicide than others. So it's really something that, again, you want to prevent. And we've been talking about medications and therapy, but as we see rightly in your case, relationships are the most important. Supportive environment, supportive relationships at work. And I know he's working, and with friends, that's also part of treatment. That's not something that can be separated from treatment. Supportive relations, friends who identify changes in patterns and can get him to therapy are all part of the treatment.
You're saying that suicidal thoughts is more in patients suffering from bipolar disorder.
It's 20 times higher. You're talking about 2000%.
So Mriganko, let me ask you here, if there is somebody who is currently going through, suicidal thoughts, which is fairly common, as we have just heard Dr. Singh say, in cases of bipolar disorder, what is the message that you have?
I think that it's important to know that you're not alone, and there are people who are trained to cater to such issues, and it's very important to seek help.
And what can they do if they are by themselves? What are some of the things that you advise, that you have done, that has worked for you?
There is one thing that has worked for me. I started writing letters to people that I love. And most of them turned out to be apologies. Then by the end of it, I was like, if there are so many people who love me so much, and I know that they love me, then what am I leaving this world for?
That's a
Yeah.
wonderful thought, Mriganko.
Yeah.
Thank you for sharing that. So reality is
Yeah.
much like heart disease, diabetes, or even hypertension. Mental health issues like bipolar disorder needs medication and constant monitoring. And more importantly, management. Mriganko is living proof that you can lead a perfectly normal life despite bipolar disorder. But it does require time and patience in accepting this not so normal reality. So, Mriganko, how long has it taken you to come to terms with bipolar disorder and accept this reality?
I still haven't come to terms with it. And I don't know if I ever will. I mean, I've come to terms with my medication and therapy. I know that I need to talk to my therapist once in 2 weeks and take a fistful of medicines every night, but I still uh, have a sense of belief that this might go away someday.
Why don't you share with us 5 things that you practice that keeps you on track?
Number one is medication and therapy in parallel. That is non-negotiable. That's the most important. Number two is recognizing and building a support system of your own. You have to know who to talk to when you have a certain problem. Number three is it's very important to know your triggers. I myself don't know what my triggers. I know one of them. I know examinations, upcoming examinations cause depression for me. So that's one. Number four is physical activity combined with nutrition. It is very important to do something physical that I realized very late in life. So swimming was one thing that I used to do pre-COVID, and then now I go to the gym 5 days a week. That covers my physical activity, and I walk. It's very important to have a diet rich in vitamins, minerals, proteins, and carbohydrates and fats. A balanced diet, basically, what we learned in school. I additionally take, with my medication, I take dietary supplements, vitamin C, vitamin D, vitamin E, iron. Also, spending time with yourself, reading, watching movies, watching series, something creative like art, painting, dance, music, maybe learn an instrument. But it's very important to do these things to keep up your mood at all times.
I like how you stressed on not just therapy and medication and building a support system, but you've also talked a lot about physical activity and nutrition. Mrs. Banerjee, 5 things according to you as a mother or a caretaker that helps someone with bipolar disorder keep on track.
I think it'll be more than five, Shruti. First and foremost, when your child is diagnosed with or your loved one is diagnosed with bipolar disorder, you have to accept it. And you have to accept it as an ailment. It could have been anything. If it is bipolar today, it could have been diabetes, it could have been hypertension, it could have been anything, a kidney ailment, it could have been anything. So the first and foremost thing is that you have to accept it. It takes time, it takes a lot of effort, but once you have accepted, then comes the next thing, that you have to now accept this child, suffering from this ailment. You cannot make it his identity that Mriganko is bipolar. I would rather say that he suffers from a mood disorder, not to make an issue out of it and make it his identity. That's a very wrong thing to do. Then the second thing is that you have to treat that person absolutely normally, like any other person. No indulgences in behavior, like no special treatment, like just because he is suffering from some kind of a disorder, you don't start treating the person differently. That is when you are I think stigmatizing. You just have to accept him, and it has to be a normal, like any other person. I won't say that when the moods are low, or when there are ups and downs, you do the same thing. No, that time you have to change your behavior because it's required, but not on the normal days. And like he said, another thing is a strong support system. You have to create that. You have to tell everyone who is in contact with him daily, and to always be alert. And the moment they feel that something is not okay, to inform us. Then I think another thing is to encourage the person to auto recognize the triggers. Like he said, it's very important to auto recognize. And of course, diet, medication, and lifestyle, along with medication, counseling. So these are the three things I always say: diet, medication, and therapy, and lifestyle. These are three things they have to be very careful all their lives, because they are on so much of medication. That's the logic I give, that you have to maintain a nice good lifestyle and do normal things, all that the others your age are doing. Have fun, do everything, but then you have to maintain your health first, so that you can sustain that kind of medication.
I like what you said. You treat him normally and don't make it his identity. Dr. Singh, what would be the 5 things, according to you, that are critical for leading a next to normal life with bipolar disorder?
So first of all, I don't think I have anything to add. You've sort of stolen all my lines, but I'm still going to try to sort of finesse that a little bit. One thing, Ms. Mitali, that you suggested was, I think in terms of identity, it's important to recognize, and we tell our patients, is that you are not bipolar. You are a person who lives with bipolar. So that distinction is very, very important. It's a small distinction, and we sometimes forget how we address a person, but that making that distinction that, you have a condition. You are that person that is much more wholesome. You do things, you write letters, you go to work, you have a family, life, mother. So I think making that distinction is important. Other thing that I'll add, and I'm sure you're aware, is this issue of sleep. Sleep is a very important component of bipolar, both as a trigger for mania and as an early symptom of relapse. So what we are worried about in bipolar is relapse. You are treated for the initial episodes and as these. So I think watching out on your sleep. So to add diet, exercise, you want to add sleep. Then again, in treatment, I will add early treatment and aggressive treatment. So, not treatment, not waiting till the last moment that we have to take him, recognizing symptoms early, getting the appropriate help, getting psychiatric help, right level of expertise, and starting a treatment. And then once you are on treatment, adherence to treatment, it's hard. Adherence, taking daily medications and daily, frequent psychotherapy or different kinds is hard. It's not easy to take pills for long periods of time. Antibiotics 2 weeks is one thing. Medications that most likely you're going to take for lifelong is a hard pill to swallow. So I think that's the other part of that. And then I'll just, and I know we're going to talk about it briefly, is just realizing that you have this, just like diabetes, just like cancer, we're going to treat it. And acceptance is hard. Acceptance is a very sort of, I don't think that, acceptance is hard. People get cancer. They're like, well, why did I get cancer? Why didn't somebody else? So acceptance is hard. And if you look at sort of the history of bipolar disorder, they are very creative people, but sometimes some of the episodes are precipitated by ambition. They couldn't meet this ambition or get this goal. So then you just have to live with that, this is your life. This is what you could do. And this is what, so acceptance to what you are as a person in some way, whatever you could achieve is okay. And I think one of those triggers of bipolar is this: people are ambitious at a certain level and weren't able to achieve that. So there's a disconnect between their current level of achievement versus their aspiration. So we have to accept that reality.
I don't think very many people have thought about their inability to meet expectations could also be a trigger to mental health episodes as serious as bipolar disorder. Very quickly, let me ask all three of you, what are some of the signs to watch out for? Let's start with you, Mrs. Banerjee.
Sadness. I think for us, it started with a confusion, sadness, and also I would say another thing, that as a child, he was very fidgety, he was very naughty, and then we would just pass it off as naughtiness, that he's too energetic, couldn't make him sit for too long. But then when he got down to his work, when he went to school, then he was very calm, and they said that he's a very nice, very well behaved child. The attention span would bother me, and we always thought that maybe he suffers from an attention deficiency or something like that. But we still did not take him to a doctor. And when he grew up a little, then I did want to take him. He wouldn't agree. He wouldn't agree, he didn't want to go to the doctor. So I think when, as a child, everyone should watch out, for any behavior in excess, and just go and see a doctor. If he's okay, then that's okay. And if there is something wrong, then the doctor is going to treat it. That's an early detection. It's all the better.
Mriganko, what are some of the signs that you watch out for?
So I sometimes help people. Like if they're at the elevator, I hold their bag, or I ask them which floor they're going to get off at, and I hit the button. And I always mistake that for a probable high. And that is something very wrong that I do. Just because I'm talking to someone that I don't know can't always mean that I'm not well. Also, if I'm ever sad, then immediately my head goes to, oh my God, am I depressed? Is this happening all over again? And that is also not a good thing. When I'm binging Grey's Anatomy late at night and I'm bawling my eyes out, that is when I again think that, am I doing the right thing? Should I just go off to sleep? So these are the signs that I think we should watch out for. And it's good to evaluate these signs. There shouldn't be a hasty conclusion from these signs. They need to be evaluated, and you need to think logically that is this what I think it is, or is this just normal behavior?
And also not to be too hard on yourself. The sense that I get is that you're very hard on yourself, right? Dr. Singh, do you want to add to any signs to watch out for?
In the initial episode, apart from the manic and depressive symptoms that we discussed, I think an important clue is high functioning individuals, people who are doing well at work and well at school, and suddenly it changes, something happens. So I think those signs need reevaluation, whether it's bipolar or depression or psychosis. So I think change in function, social function at school, function at work. So that requires evaluation. And same thing, once you've had the diagnosis, and I would add again, and I'm re-emphasizing, sleep as a trigger, sleep as a symptom. In depression, the inability to feel pleasure. It is not that you cannot be sad. We are human. We are going to be sad. And I think it's okay to be sad. It's not that you cannot experience joy. We need to experience joy. But that there is that fine line between excessive sadness or excessive spending that spills into mania or spills into depression. And others around you, your partner, your friends can help you. Sometimes there are somatic, like physical signs, faces are flushed, or by your look, people can get you're getting into this manic phase. Speech will be changed. So I think for those who have had a diagnosis, building a support system around them, in your case, your mother, your friends who can recognize this is very helpful.
So one last thing before we wind up is that unfortunately there is stigma attached to mental health conditions, especially bipolar disorder. And I want all three of you very quickly to tell us how best people can handle stigma of being labeled mentally unfit. So Mriganko, let's start with you.
So luckily, so far, no one has stigmatized my condition. But if that does happen, I am prepared for it. I would just tell them to leave me alone. Not in such beautiful words, but yeah.
I think there is a reason why you don't feel stigmatized. And I want to ask Mrs. Banerjee that there is stigma, but why do you not feel it?
That's because I don't believe in it.
Exactly.
It's not there in my head. There is no reason for stigma because I don't believe it, so I don't see it. I think there's no reason because it's just another condition, and my child has been diagnosed with it. He's on medication. He's leading a normal life, and his behavior is much better than so many other people who I see are normal. And another thing I feel is that he's my child. He's a gift to me, and I have to accept him. This is an imperfection. I just take it not even as an ailment. It's just an imperfection. That's okay. There are children born with a hole in the heart, or then spina bifida, or there are so many, hair lip. So this is another one. My child has come to me with an imperfection. It's perfectly okay with me. I have no problem.
Dr. Singh, how do you, as a medical practitioner, approach this whole concept of stigma?
That's something that's less medical, more social in the psychosocial context. It's different in America, where there's still stigma attached with mental illness. Stigma it require things like what we are doing today, conversations around mental illness, just treating people as equals, getting people help, and creating those resources. We need to create resources in India for people. You've been lucky to have a family that is supportive. But a lot of people in rural areas, suburban areas, they're not diagnosed. So, whatever we can do, at least starting out with conversations and getting the help, it'll get a long way in reducing stigma.
Really, and I'd like to add here that it's not just people who suffer from bipolar disorder that need help. Caregivers too need assistance and to take care of their own mental health, because it's certainly not an easy journey for them. And just to sum it up, medication is very much part and parcel of a serious mental health condition like bipolar disorder. And it may take several trial and errors till you reach a level of stability. Caregivers keep a close tab and take control. Watch out for those signs that only you can. You need to be vigilant. I cannot but stress on this. And along with medication, of course, we cannot stress enough on the importance of, as Mriganko mentioned, physical exercise and nutrition. That really should be like a daily practice, because there is enough proof that it goes a long way in reducing overall stress, and not just keep patients, but also caregivers on track, focused and mindful. So thank you, Mriganko, for sharing your story so candidly and for being such a warrior living with bipolar disorder. Thank you,
So much.
Banerjee, for helping Mriganko through his journey and so lovingly yet strictly ensuring that he lives as close to a normal life that he can, and for saying that stigma is in the mind. I think all of us should take note of that. If you as a family don't buy into this stigma, what judgmental acquaintances and strangers think or say shouldn't matter. And thank you, Dr. Singh, for joining us all the way from Massachusetts and sharing such insightful inputs. Thank you all for being on Zen-Brain.
Thank you, Suzy. Thank you.
Thanks, Dr. Singh. We got to learn a lot from you today.
I learned a lot from Mriganko and you.
Thank you so much.
Yes, there were a lot of things that got really clear today. When I was listening to you, I see so much the sleep and all of that. Thank you so much. And thank you so much, Shruti, for your efforts. It really helped. Thank you so much for bringing us together.